We're here today with Dr. Adjoa Anyane-Yeboa. She's a board-certified gastroenterologist at Mass General Hospital and instructor of medicine at Harvard Medical School. She's also a member of the Clinical and Translational Epidemiology Unit, which is a subdivision of the Mangone Institute at MGH. Her work focuses on health equity in gastroenterology, specifically in inflammatory bowel disease and colorectal cancer. However, today we have the pleasure of speaking with Dr. Anyane-Yeboa about celiac disease. So thank you so much for being here today.
Thank you so much for having me. It's an honor.
So much of your medical career thus far in advocacy is focused on eliminating health disparities, fighting inequalities, and improving access and quality of care for vulnerable individuals and populations. So when it comes to celiac disease, we know that screening and diagnosis are important. So how much do health inequities impact how and if Black patients are screened, diagnosed, and treated for celiac disease?
So that's a wonderful question. Thank you for asking that, and a really important question, because we know that there are disparities in celiac disease. We know that people have assumptions of who celiac disease affects and who it doesn't affect. And actually, there's been studies that suggest that celiac disease might actually be underdiagnosed in Black populations and other minority populations. So there's research that I did, while I was in fellowship, looking at patients who came in with iron deficiency, anemia, and diarrhea on two separate occasions spaced out by 6 months. And in this study, we found that people who were likely to have or less likely to have an appropriate workup, which we defined as a colonoscopy and endoscopy or celiac serologies, because these are diagnoses that could be suggestive. Iron deficiency, anemia, and diarrhea can be suggestive of IBD and celiac. But those who were less likely to be worked up were those who were Black or on public insurance. So we know that there are disparities. And so if we're not thinking and looking for celiac, then the likelihood that we're going to be diagnosing people is low. So there might be many people out there who have symptoms of celiac disease where they go to their providers and nobody's looking for it. There was actually a study as well that looked at patients who actually did go to EGD. So they had, symptoms suggestive of celiac, they had an EGD, and those that were less likely to be biopsied for celiac were Black, because again, people aren't thinking about it. So people have these symptoms, they might be suggestive of celiac disease, and even when you get to the procedure, people aren't looking for it. And so it could be that celiac disease is underdiagnosed. And I think it's really important for all providers to have it at the top of their minds that celiac disease impacts everybody, and that we're not going to only look for it in certain populations, because everybody can get celiac disease, not just the populations that we historically associated with celiac.
Yeah, it's so important because we have so many stories of patients who have years and years of not feeling well before ultimately their diagnosis of celiac disease. So really hearing that, there's a group that, is not having a biopsy, even though they're in there is something that, we really need to focus on.
Absolutely. And I think it's also important for patients to know about celiac disease and that everybody can have celiac. So even if providers aren't thinking about it, then as a patient, you can say, could this be celiac disease? Should I have a blood test for that? So even if the providers aren't thinking about it, as a patient, you can always advocate for yourself, which I think is also really important.
Absolutely. And we talk about that in our celiac clinic and just testing other family members. So again, advocating for yourself is so important. And that sort of leads us to sort of the estimated prevalence of celiac disease. So it's thought to be about 1% in the United States. Do we think the prevalence is different in Black people?
So there was actually a study that came out in about 2015 using NHANES data. So they looked at about 15,000 patients that were checked for tissue transglutaminase and endomysial antibodies, which we use to diagnose celiac. They found that actually in that study, the prevalence of celiac disease was about 0.8. And so the prevalence of positive serologies by race in that study, so about 1% in those who are non-Hispanic white and about 2% in those who were Black. So yes, the prevalence of celiac disease is higher in white populations, but it's not zero in other populations. And just because it's lower doesn't mean that we shouldn't be looking for it. And actually, in the same study, they found that minorities were actually more likely to have a positive anti-tissue transglutaminase antibody. And so it might be that the threshold of these, blood tests might be lower in these groups, and that they might not present as we have traditionally thought people present, because we're not studying it enough in these populations. So I definitely think there's more to be learned.
Wow, definitely. Great, thank you.
Right.
And in your research, sort of what are the social determinants that have influenced how and if persons of color are screened and treated for celiac disease?
Yes. So the social determinants of health. So the definition of the social determinants of health are the conditions in which people are born, grow, work, live, and age, in the wider set of forces and systems shaping the conditions of daily life. So these forces and systems include economic policies, development agendas, social norms, social policies, and political systems. So these social determinants often underlie disparities in health. There's different categories of the social determinants. So there's like economic stability and whether or not people are employed, whether or not they have enough to make a living wage. Oftentimes, health insurance is tied to employment. So if you have a low paying job, you might not have access to coverage, and therefore you might not have a usual provider. And it might be difficult for you to get these blood tests because they might be really expensive out of pocket. There's also, we think about the neighborhood and physical environment, where you live, and if you have transportation and access to green space. We think about education and food, which is really important in celiac disease, access to gluten-free diet. How easy is it for you to keep up with a gluten-free diet? I think is really important as well. Do you live in a food desert where it's not, things might not be labeled gluten-free at all, and you kind of have to just figure it out yourself? And then we also think about the community and social context and the healthcare system. So these social determinants often underlie health disparities, and inequities in these social determinants often leave certain populations at a baseline of disadvantage.
Oh, thank you. Great. I think our last question for today is just sort of how can we do better? So how can we help get healthcare providers to really deliver more equitable levels of screening, diagnosis, and care?
Absolutely. So I think the first thing is knowledge and education, and making sure that all providers are aware that everybody gets celiac disease, and it's not just some populations, but it's everybody. I think it's really important as well to think about access. I think, oftentimes if you're sitting in clinic and you're seeing only certain populations coming in and not other populations, asking, why can that be? Is it because, is there a barrier to, getting to our facility? Is it the insurance coverage that we take? Are there other factors? Is it the hours of our clinic? Are there other factors that are making it difficult for patients to access care? And then I also think it's really important as providers and as health systems to have partnerships in the community, partnerships with healthy eating organizations or healthy food organizations, and, working around advocacy in this way, and, working in at a farmer's market, or having, a farmer's market at the hospital, or, getting into the community and doing these things, and thinking about exercise. And also, I think it's important for providers to practice in the community as well, because we do know as well that patients, particularly at community health centers, often have difficulties accessing specialized care. And so, patients who are at community health centers are often, disproportionately minorities, often those who are low income. We know that's a barrier. We know there's a barrier to specialty care. And I think as specialists, we need to think about how we practice and how can we be more creative in our models of practice. And so I actually do work at a community health center in Boston. And I have a colleague who also works, who's GI, who also works at a community health center in Boston as well. And there are different community health centers to make sure that, more patients have access. So I think it's really important for us to think about different models of care and how can we reach more patients. And then we also need to think about policy and what can be done at the policy level to, work towards equity in these social determinants of health, to improve access, to think about coverage. Oftentimes, change requires things at the policy level as well. So I think that's something really important to consider.
Great. Well, Thank you so much for taking the time to speak with us. You know, this is such a big issue in celiac disease. There's so many patients that are undiagnosed, and there's still this this thought that it's really affecting, you know, just people, just you know, predominantly white people from Europe. So we really have to change the narrative here,
Absolutely.
and sort of I hope that this is the start of some future work together. So thanks so much.